सुशील जी।
हाँ सर नमस्ते। सर नमस्ते। सर नमस्ते।
नमस्ते, मुझे प्रेजेंटर बना दोगे अभी?
हाँ सर बिल्कुल रेडी हूँ, आई एम रेडी।
ठीक है, ऑलराइट।
ओके सर।
मैं इसे ना स्पीकर पे डाल देता हूँ।
अच्छा ठीक है सर। सर किस नाम से आ रहा होगा आपका?
टोनी जॉर्ज जी का।
एक मिनट सर।
EGJ करके आ रहा होगा।
हाँ ठीक है सर, मिल गया।
ठीक है ना?
हाँ जी सर।
हम 6 ही लोग हैं अभी।
अच्छा तो ठीक है सर, बना दो फिर, प्रेजेंटर बना दूँ आपको?
हाँ, बना दो।
ओके सर, हो गया, आपको बना दिया।
अ, क्या? दिख रहा है अब स्क्रीन?
हाँ हाँ बिल्कुल बिल्कुल एकदम क्लियर है सर।
ओके, ठीक है।
मैं
अच्छा, एक
मैं
मिनट
भी एक बार चेक कर
इसमें।
लेता हूँ ना फ़ोन पे।
हाँ, ठीक है। एंड आप ही वो यूट्यूब का भी स्ट्रीमिंग करोगे ना?
हाँ हाँ वो सब मैं करूँगा सर, आप वो बस वो प्रेजेंटेशन देंगे अभी आप।
ठीक है, ऑलराइट।
मैं माइक बंद कर रहा हूँ सर अपने यहाँ का ना।
हाँ, हाँ, श्योर, 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 कैरी
ठीक है
ऑन।
सर, ओके सर। एक बारी आपने चेक कर,
अच्छा, मैं।
आपने एक बारी चेक करके बता
हाँ,
दीजिए।
क्या है?
मैं कहता सर कि एक बारी आप चेक करके बता दीजिए आपकी वॉइस
हाँ,
ऑडिबल ऑडिबल है या नहीं अभी?
अभी तो ऑडिबल है।
हाँ है ना?
आपको ऑडिबल है?
हाँ जी हाँ जी, यस
हाँ,
यस क्लियर है सर।
ठीक है, ऑलराइट। एंड प्रेजेंटेशन भी दिख रहा है ना, सब कुछ दिख रहा है?
हाँ सर दिख रहा है, एकदम सही चल रहा है।
ठीक है, ऑलराइट।
Yes, sir.
अच्छा,
We can see. Good morning, sir.
गुड मॉर्निंग। गुड मॉर्निंग हरीशा। अच्छा,
Yes, sir. You're audible.
तो मैं 10 बजे को शुरू कर दूंगा, ठीक है?
ठीक है सर।
और थैंक्स। Good morning, batch of 2020. I'm Tony and I'm an associate professor in the Department of Anatomy. So the topic that has been given to me is first and foremost learning embryology, and the main topic for today is gametogenesis and germ cells. So you've already had a week or two of classes that have been going on in anatomy, and this is going to be your first class in embryology. But more importantly, I would like to welcome you to a university. So far you've been in school. I'm stating the obvious, but that's a national pastime in our country. But yes, so you've been in school and you had a curriculum which is quite well prescribed, and there are things that you're supposed to know, which you're supposed to reproduce in an examination system, and you are evaluated accordingly. And you've all been, at some point in time or the other, toppers in your batches in schools and state levels and so on and so forth. Now, university is slightly different, particularly a medical university, because as the name itself suggests, the entire university is school for all practical purposes. So, what I usually tell my students in the very first lecture is never ever trust your teachers. Now, that's a very strong statement to make for the simple reason that at the university, you are empowered to seek knowledge. And today, with your smartphones and tablets and laptops and computers and everything else, all sorts of electronic devices, you have access to worldwide knowledge and universal knowledge. And therefore, you're not restricted to a library. You're not restricted to the electronic books. You're not restricted to any sort of publications. The entire world, the entire universe is yours to know. Which is why it becomes important for you to understand that what a teacher presents to you or teaches you is what they have distilled from what they would have read. And therefore, what you are getting technically is second-hand information. So the only thing that you can actually look towards your teachers is probably less of information and more of perspective. Because that is one advantage that your teachers have over you, is that they've got experience. And over the years that they've been teaching or they've been learning about a particular subject, their perspective about the subject changes. And what they provide you is essentially just that, a guiding light if at all. Many of you may be empowered yourself to find your own light and go ahead and do it. The only thing is that there is nothing called right and wrong. There's no binaries of right and wrong in the university. You just seek knowledge. And that seeking of knowledge is going to last you an entire lifetime, particularly in our profession, because information, knowledge just keeps on getting updated on a day-to-day basis. And there is no dearth of that information. And how you use that information in your patient care, in the way you deal with your colleagues, in the way that you comport yourself as an academician, as a doctor, is going to be essentially based on updating your knowledge on a daily basis. And therefore, the prescription of a textbook in 2020 may not hold true when you start your clinical practice, or when you become an academician, or when you become a professor, and so on. Which is why getting out of the habit of school and empowering yourself in the seeking of knowledge is an important step in becoming a student at the university. And one of the basic principles that you are already aware of by now is that knowledge is going to be an essential part of your path, particularly as a doctor. And the better sense of knowledge that you have, the better you're able to teach. So essentially you must understand that the word doctor does not actually mean a physician or somebody who treats patients. The root word for doctor is dokiri or dotteri, depending on whether you're looking at Greek or in Latin. Dokiri is also derived from the word from which you get the word dogma. So the person who teaches dogma is the dokiri. So usually dokiri was referred to as the teacher. So as a doctor, your primary role will also be that of a teacher, because when a patient comes to you, you not only understand what is the problem with them, but you're also supposed to explain it to them. And the way that you explain it to them in simple terms is going to be entirely anchored on how knowledgeable you are about that subject. And so your entire reputation as a doctor very often is going to be grounded in your knowledge and anchored in your knowledge. And that knowledge is not necessarily going to be reflected in your academic performance. You yourself know from experience that when you go to a doctor's clinic, rarely would you ever see their first professional marks or whether they passed their final professional exam first attempt, second attempt, or for that matter, what marks they got in the MD exam or the MS exam and so on and so forth. So those marks are of absolutely no value when a patient comes to a doctor. But how you deal with them, how you communicate with them, how you treat them is all going to be contributing to your reputation. And that reputation is something that is going to be valuable to you and is going to be essential to you as not only a doctor, but also an academician. And this is a basic tenet of medical sciences and medical art. Primum non nocere or non nocere, depends on how you want to pronounce it. Which primarily means that firstly do no harm. This basic principle of medical ethics and of medical knowledge and medical practice is an essential that you need to have always in the back of your mind. That primarily you should be doing no harm to the patient. No treatment, no statement, no information that you provide to the patient should harm the patient or should be worse than the disease itself. And this kind of harm can also be produced in your words. Like what Yudhishthira had said at his time with the Virat Raja, Satyam Bruya, Priyam Bruya, Na Bruya, Satyam Apriya, which means you can say the truth. You should say what is good, and you should not always tell the truth that is unpleasant. And so there are multiple principles that keep intervening themselves in different practices of medicine, different schools of medicine, but the ethic always underlying is to do no harm. And the way that you do no harm is to be sufficiently knowledgeable and have adequate communication skills in order to treat or even communicate with the patient. Now, when you come to university, as I said, an important part of your education is going to be seeking that knowledge. And today, since knowledge is available everywhere, even at your fingertip, on your smartphone, on your laptops, and what have you, it becomes essential that you analyze that knowledge. And the basic principles of any logical analysis is going to be these set of questions. If you're able to answer these questions or find answers to these questions, you would have a relatively wholesome view of the question in hand or a situation in hand. And these these are going to be your best friends all your life. So who or what, where, when, why, and how. And the order of these questions can keep changing depending on the situation. But if you are able to find answers to these 6 questions, you would have a relatively 360-degree picture of any situation at hand. And it's therefore coming to an essential part of embryology that you're going to be starting today is going to be through this analysis. Let's see. So who's going to be learning embryology today? Or for the rest of your lives? It's going to be you, first and foremost, and it's going to be evaluated as well. In your exam, it's a small percentage of your evaluation, but it's an essential part of your evaluation as well. And through you, you're going to be benefiting your relatives, your friends, your colleagues, your patients, as well as your students when it comes to that day. And today, now that you are in a medical school or a medical university, a lot of your friends and relatives would be checking with you for medical information. It could be related to a pregnancy, it could be related to a visit to the hospital, it could be related to a scan, a report of some investigation or the other. The moment you enter into medical school, people already think that you're half a doctor, and therefore why not check with him for a second opinion, or her, to get to know as to whether what is happening in the hospital or in the clinic is alright. And therefore, your knowledge of embryology is going to be an essential part of your knowledge, because it helps to know what is happening in the developmental process to understand what are its implications in the adult, either physiologically or even pathologically. Now, what are you going to be learning during this process? First and foremost, there is going to be 2 essential parts of learning embryology. One is the general embryology, and then there is systemic embryology. So in general embryology, you're going to be starting with gametogenesis, which is the subject of today's lecture, and then you're going to go on to fertilization next week, implantation, and embryogenesis. And this embryogenesis ends with the laying down of the groundwork for organogenesis, which is going to be part of systemic embryology. And this process of implantation will also include a lecture on the placenta, which is an important fetal-maternal unit, which is not only important for the nutrition and respiration of the fetus, but also as a hormonal unit which helps in the maintenance of pregnancy. In systemic embryology, you're going to be learning about the different organ systems, whether it be the cardiovascular system, the nervous system, and so on and so forth. In addition to that, you're going to be learning about molecular regulation development. And you're going to be having a series of lectures on genetics and genetic disorders. And one important part of your evaluation, as well as learning systemic embryology as well as general embryology, is the embryological basis of birth defects. And that usually is an essential manner in which we in the medical university evaluate a student in their knowledge of embryology. That means if there's a birth defect, we ask the student to explain what could be the mechanism by which this was produced. Then another aspect of the birth defects is stereogenesis, as to why exactly do these birth defects occur, and what are these birth defects, and are there any external influences on them or the internal influences, and so on and so forth. And that study is known as stereogenesis. So they usually also, most lectures of embryology will also deal with a certain amount of birth defects and stereogenesis. Another important part of your learning embryology is going to be how you're going to be presenting that information, and the information and understanding that information which is present in your textbooks. And a lot of it is related to color coding. You would have already been taught about the color coding when it came to general anatomy, how the muscle is shaded brown, arteries are red, veins are blue, and so on. Tendons, etc., and connective tissue is usually colored in green. Now, in the same way, there is a color coding in embryology as well. So in general embryology, blue is used to represent epiblast or ectoderm, yellow is used for hypoblast or endoderm, red is used for mesoderm, and green is used for trophoblast, which is a different kind of tissue which only occurs at the time of embryogenesis and fetal development. In systemic embryology, you may use the same color codes as in the adult, that is brown for muscle and so on and so forth, but also for certain specific structures that are there only during the developmental phase, there are certain other coded colors for which there would be a key in your textbooks. Okay, so this is another thing that you're going to be learning during your course on embryology. Now, where are you going to be learning all this? In lecture halls, or as you can see right now on a Google Meeting platform, in the microanatomy lab where you're going to be having the practicals, as well as your learning of embryology doesn't get over here with the first year. It is going to continue in the wards and the clinics, both as a student as well as a practicing clinician. Now, when are you going to be learning and what are you going to be learning with? So in the first semester, we usually deal and finish off with general embryology, genetics, epigenetics, respiratory system, and the cardiovascular system. Whereas in the second semester, we finish off with the rest of the system, that is gastrointestinal system, genitourinary system, the head and neck, the locomotor system, the nerve system, and special senses, and also you may have a lecture on teratogenesis depending on the time constraints. So that is the semester-wise distribution, but otherwise, you would have noticed in your schedule that we in the Department of Anatomy at AIIMS, usually, as well as the rest of the country as well, we deal with anatomy as regional anatomy. That means initially you have general anatomy, and right now you've started with the upper limb. Then we go on to the thorax, and finally the abdomen and pelvis. Then we go on to the head and neck, and then finally end up with the lower limb. So you would have also noticed that along with general anatomy, we are also teaching you general histology. And right now, today is the first class in general embryology. And as the regions start off, for example, you're going to be next starting with the region of the thorax. And towards the end of that region, you will have your classes on the systemic embryology of that region. For example, at the end of the thorax lectures, as well as the dissection and prosection and so on, you're going to be having the classes on the development of the respiratory system, which will deal with the tracheobronchial tree, as well as the pleural cavity, and also the cardiovascular system, which is going to be dealing with the development of the heart and the great vessels, both the venous as well as the arterial. So usually your classes of embryology are going to be towards the end of that particular region, so that you are able to understand, after knowing the adult structure, as to why that adult structure forms in the way that it does form, and what is the mechanism for its development, and whether there are any anomalies that can be explained because of that. Now, why do you need to learn this? First and foremost, as I said, there's a reason why we take these lectures towards the end of the region that we are teaching, because it also provides you with a logical framework with which to understand the adult anatomy. And unless you know the normal anatomy, it's very difficult for you to know what is distorted anatomy. And in your clinical practice, you will come across a lot of distorted anatomy later on. And it will be your knowledge of embryology which will be able to help you understand as to why this distortion is taking place and what is the mechanism by which it may be corrected or it may be treated. And this embryology is also an important bridge between the basic sciences and the clinics, because a lot of research that is happening in biomedical sciences has actually started with a lot of this kind of work being done in developmental sciences. And the impact of this knowledge of embryology is going to be there in appropriate reproductive health and contraception, in the understanding of birth defects, prenatal and postnatal development, in ICF, that is, in vitro fertilizations, in the knowledge of stem cells, of cloning, in cancer biology. In all of these fields, you're going to be having a contribution of the knowledge that is derived from anatomy, of embryology or developmental anatomy. And this developmental anatomy also forms one of the basic foundations of medicine. And today, it's also an area of extreme interest because it is also an area where there is cutting-edge research that is taking place with all sorts of tools, the latest tools that are possible. For example, you have your CRISPR-Cas9 methodology of gene editing. All that has been applied and utilized in developmental anatomy and its research. Now, how do we go about studying? So first and foremost, as I told you, you will have lectures, you will have practicals, which are based on models, chick embryo sections, ball mounts, pig embryo sections, as well as you will be provided a worksheet during the practicals. So, in our department, we use these embryo sections for you to understand what are the basic structures so that you are also able to get a visual idea about the processes for which there is a lot of theory in your textbooks. For example, if I show you this ball mount of a 40-yard chick embryo, you can easily appreciate that the embryo is a folded structure, where you can see this is the area of the head fold. This is where the prosencephalon, or what is your future brain, that is developing. And this little bulge over here is actually the bulge of the heart, the pericardial cavity. And this is where the gut tube is going to be developing, and so on. Now, these embryos are sectioned from one end to the other, which is why when you look at a section like this, you will always be able to orient yourself with the help of certain important landmarks. A very important landmark is this structure here, which is a neural tube, which is formed at the back, the future spinal cord, and the notochord, which is in front of it. So this is the dorsalmost structure. Now, if you look at this section, you can see a replication of the neural tube right over here in the front as well. Which is why I am able to tell you that this section has probably gone through this part, like this. For the simple reason that dorsally I am able to see the neural tube and the notochord, which is going to be over here. Next, I am able to see the portion of the pharynx with a portion of the heart tube. So this is going to be the future heart tube, which is going to be inside the pericardial cavity. And further in front of that, you can see that there is a prosencephalon, which is over here. So when you look at this section, you're actually recreating the embryo that looked like this. And the knowledge that this embryo is going to be universally folded is important for you to understand these structures, and this will help you also to understand how these structures are grouped. And in a slightly older form of the fetus or the embryo, we also have 10mm big sections which have been stained like this. And here again, you'll have similar points of orientation. For example, you have the neural tube with the notochord in front of it, the gut tube, this is the developing heart, and this is the developing head with the prosencephalon or the diencephalon, as the case may be. Now, apart from these sections, during your practicals, you will also see flat models like these. For example, this is a flat model, and you can also see the color scheme in it. where you can see the green represents a trophoblast, the yellow is the hypoblast, and you can see in the blue the amnioblast as well as the epiblast. So these are flat scale models which are useful for you to understand the process of what is happening. So these are essentially reproductions of figures that are there already in your textbooks. But this just gives you a kind of a feel of a large structure, and these are number coded. They usually have a key, and these are also used in your evaluation of the examination process. Now, apart from the flat models, we also have these three-dimensional models. For example, this model over here is showing the process of fertilization, where you can have multiple spermatozoa, but there's only one spermatozoa that enters, and you can see the cortical granular reaction and the completion of the second meiotic division in the ovum. Similarly, you can see that there is a three-dimensional model of the development of the inferior vena cava. This is the development of the inferior vena cava, and this is why I said that different parts of systemic embryology can use different color codes, and there will be a color that will be associated with a key for you to understand which segments are derived from what developmental structure, which will eventually form one common inferior vena cava. So you can see that the inferior vena cava is actually derived from 1, 2, 3, 4, 5, 6, 7 structures, 7 different structures, and all of them are going to be eventually blending with each other to form an adult inferior vena cava, and you're going to be learning this with the cardiovascular system. And any anomalies of the development of the inferior vena cava will be derived from any of these parts, which is why knowing these component parts and how they derive becomes an important aspect of learning developmental anatomy. So this is about how you're going to be going about learning embryology. So does anybody have any questions so far? Any doubts, any questions, any remarks related to what I've told you so far? So there's somebody who's written something on a chat. Let me just check. Hang on. No, sir. So there's absolutely no question. All right, great. So, if that's okay, can we continue? All right. So, coming on to the subject proper for today, that is going to be gametogenesis. Now, your learning objectives for gametogenesis are going to be certain terminologies like phases and trimesters. Then we're going to be discussing the primordial germ cells, the timelines of the development of the primordial germ cells, then specific gametogenesis, that is either spermatogenesis or oogenesis, depending on the sex of the individual. Cytodifferentiation, which is how something that is looking like a round cell, which is a spermatid, becomes this tadpole-like spermatozoa, or similarly, how a tiny round cell, which is the primordial germ cell, eventually becomes an oocyte, which is ovulated and released into the fallopian cavity in the females. Along with that, we're going to be discussing certain abnormalities of gametogenesis, and I will end with an note on contraception and control of fertility, which technically is going to be dealt with again in your class on fertilization, because essentially the prevention of fertilization is contraception. So, your developmental periods can be divided clinically into trimesters, which are either prenatal or the postnatal development. So in the prenatal development, there are 3 trimesters, which are not exactly as per 3 months. Each trimester technically means 3 months. So the first trimester usually covers from the first 3 months. The second trimester usually 4 to 6 months. And the third trimester is usually 7 months to birth. Now, postnatal development also has has certain phases, like the neonatal period, which is usually up to 28 days after birth. And then you've got infancy, which is up to 1 to 2 years of age. Then you have childhood, then adolescence, which usually starts at the time of puberty, then adulthood, and we go on to the elderly phase, where the person becomes aged. The age for marking somebody as elderly varies from different countries. There are WHO guidelines, and those guidelines also keep on changing. And currently, it is usually taken as 60 years and above, which is also the time for retirement. Then you have developmental periods. For example, you've got the pre-implantation period, which is from the formation of the egg or the ovulation to 0 to 3 weeks. So this lasts for about 3 weeks, by which time the implantation process is completed in the wall of the endometrium of the uterus. Then we've got the post-implantation period, which is from the formation of the embryo, that is the end of 3 weeks to up to 4 to 8 weeks. And then you've got the stage of the fetus, which is from 9 weeks to birth. And then you've got the postnatal period, which is similar to what we saw in the clinical phases of the postnatal development, that is neonatal period, infantile period, childhood, adolescence, adulthood, and aged, the elderly. Now, in embryogenesis itself, there are different phases. For example, you've got the gametogenesis, which we are going to be dealing with today. Then after the formation of gametes, we've got the fertilization. Then we go on to the cleavage till the formation of the blastocyst. Then there is gastronation, where all 3 germ layers are laid down, and the basic foundation of the organ systems are also laid down. Then there is a folding of the trila minor nucleus, which forms the embryo in the initial phase. And then you have the formation of the tube within tube format. And finally, we're going to be dealing with organogenesis. Now, this formation of the tube within tube is extremely important, because this is exactly what we resemble. That means we've got a tube inside, which is lined by endoderm, that is the gut tube. And you've got a tube outside, which is derived from endoderm, that is the skin that is covering your body. And in between them lie structures that are usually derived from the mesoderm, whether it be smooth muscle or skeletal muscle, whether it be bone, connective tissue, all of those, including blood vessels, all of them are derived from the mesoderm. So you've got an outer covering, an inner lining, and you've got the mesoderm in between. So that basic tube within tube is laid down by the folding of the embryo. Alright? So, certain definitions before we get ahead. First and foremost is gametogenesis, which we're going to be dealing with today, which is the process of formation of the gametes from the primordial germ cells. Then PGCs, or primordial germ cells, are the precursor cells for the gametes. What are gametes? Gametes are the specialized cells. So all these definitions are there. You will have these, have this presentation. I will post it on the Surrey platform. You can have a look at it whenever you feel like. And your reference book for embryology is going to be Langman's. That's a basic textbook that we recommend at our institution. It's a pretty simple book. It may be slightly abbreviated for many students, but for most purposes, Langman is more than enough for you in your particular phase in life. But otherwise, if you ever need further clarifications, you can always take the help of Google Baba, or you can ask one of us, or you can use any sorts of other textbooks. And for example, there's Larson's, there's Carlson, there's a whole lot of other textbooks that are available for embryology. Okay. Next. So gametogenesis itself is entire process from the primordial germ cell to the formation of the gamete, and this is usually in 4 phases. So the first phase is the origin of the primordial germ cell. The second phase is the increase in the number of the primordial germ cells by mitosis. Then in the phase 3, you've got the reduction of the chromosomal number by meiosis. And finally, in phase 4, you've got the maturation of the gametes and the cytodifferentiation, which will help in forming the mature gamete, which will be ready for fertilization. Now, this is the concept that you must understand. What is ploidy and what is N number? So ploidy is the number of copies of each chromosome that is present in a cell nucleus. If it is a perfect multiple of 23, then it is known as euploid. If it is not a multiple of 23, then it is known as aneuploid. Now, N number is the number of copies of each unique double-stranded DNA molecule that is present in the nucleus. So each chromosome contains 1 or 2 copies of the DNA depending on the stage of the cell cycle, whether it is mitotic cell division or meiotic cell division. Okay? So this is a concept that you are all aware of already. And this same concept has been replicated in this table, where you can see the general term of gametogonium, primary gametocyte, which in males will be a spermatocyte, and in a female it would be an oocyte. To the formation of the gametid and to the gamete. So you can see the difference between the ploidy and the number of chromosomes as to whether it is diploid or haploid. And you can see it is a secondary gametocyte, secondary spermatocyte, secondary oocyte that actually has a haploid number of chromosomes, which happens after the first meiotic division. Till then, a lot of the spermatogonia and oogonia actually divide by mitosis to keep on increasing their cell number. And there are differences in the process of oogenesis and spermatogenesis, which I'm going to be dealing with during the subsequent slides. Okay. Now, starting with the first phase, that is gametogenesis. Now, where do these primordial germ cells originate? Now, all cells that will eventually form us arise from the epiblast. So the epiblast is the upper layer of cells which face the amniotic cavity as compared to the hypoblast, which are lining the primordial yolk sac. So every cell in the body, including the embryo itself, is actually derived from this epiblast. And it is after the formation of the 3 germ layers that the epiblast disappears and it is replaced by or renamed as the ectoderm. So within the second week of intrauterine life itself, the epiblasts that are meant to form or are destined to form the primordial germ cells, which are pluripotent stem cells like the epiblast cells themselves, they migrate and hide in the wall of the yolk sac, initially as part of the hypoblast and later from the 3rd week onwards, where it is known as the endoderm. Now, it's a good question as to why. Now, if you understand basic concept of physics, the least activity of angular velocity in any rotatory activity will always be at the axis. So, if you remember, I talked to you about the formation of the tube within the tube, which is our basic body plan, where you have the ectoderm outside and the endoderm inside, and in between you have the mesoderm. So if we are forming a tube by the folding of the embryo, please understand that this folding is not an active process, it's technically a passive process. Why do I call it a passive process? Mostly a passive process is because the endoderm endoderm is technically a place where the least amount of activity is taking place and the least amount of growth is taking place. And that is why it forms the axis for the folding. There is maximum amount of developmental activity during this week of development, that is second, third, and fourth week of development, is actually taking place in the epiglottis and the ectoderm. Why? Because you've got the formation of the neural plate, the entire neural tube is forming, there's a lot of mesoderm that is developing under it. So there's a rapid growth of structures that are derived from the ectoderm. And if this amount of differentiation and growth is taking place in that layer, you can understand that there will be a storm of chemical factors that must be there in the vicinity of that ectoderm. So if that is the case, you can clearly understand that any cell in that vicinity or in that neighborhood will have a tendency to be influenced by all the chemical factors and genetic factors that are there in that neighborhood. And therefore, these cells can also differentiate into whatever be the stimulus in that particular locality. Hence, it becomes essential that those cells that are going to be forming primordial germ cells, which have to remain pluripotent throughout, should be hidden from all these influences. Which is why it is sent or it migrates to a region where there is the least amount of these chemical factors that are floating around the place, and that is in the ectoderm. And therefore, during the second week to the fourth week, these cells go and actually hide inside the ectoderm or in the wall of the yolk sac. So please understand this concept that even the primordial germ cells, because even your Wikipedia and some of the older textbooks tell that primordial germ cells arise from the wall of the yolk sac. That is incorrect. That means you are giving it an endodermal origin, which is incorrect. The primordial germ cells also arise from the epiblast, but during the second week itself, they migrate and hide in the wall of the yolk sac where there is the least amount of activity. And from there, after the entire cytokine and chemical storm in the ectoderm is relatively settled and most of the cells have differentiated into what they were supposed to have differentiated, these cells start migrating from the wall of the yolk sac back into the region which is going to become the future gonad. That is the reason why initially when people had done the research on this area, they thought that these primordial germ cells were actually migrating from the endoderm. They had not seen the phase that was there before, wherein they migrated from the epiblast into the endodermal area and then re-migrated from the endoderm towards the gonadal ridge. Okay? So there are two migrations. One from the epiblast to the endoderm or the yolk sac, and then there's a second migration from the yolk sac back into the gonadal ridge. So, during the second phase of gametogenesis, the primordial germ cells, they migrate, and there are two migrations, as I said, between the third to the fourth weeks, they are in the wall of the yolk sac, and then after the fourth week, that means after neurulation has taken place and the gonadal ridge has formed in the wall of the gut, near the wall of near the dorsal wall of the embryo, these migrate. Now, if you look at this, this is a folded embryo where you can see this is the tail fold, that is the tail fold, and just proximal to the tail fold, you can see the allantois, which is going to become the apex of the urinary bladder. And this is the yolk sac, which becomes the gut tube, and what is in direct continuation with the yolk sac in the midgut. Proximal to it into the head fold is the foregut, and near the tail fold is the hindgut. Okay. Now you can understand that the epiblast cells that were forming the primordial germ cells migrated to the wall of the yolk sac. Thereafter, you can see that this allantois is very close to the tail fold of the gut tube. And it is near the tail fold of the gut tube that we also have the gonadal ridge, which is developed from the mesoderm. It develops from the mesoderm. Okay. So now, traveling through the wall of the yolk sac or the gut tube, it reaches the dorsal wall of the embryo and invades into the gonadal ridge. So if I cut a section, a transverse section of the embryo, it will look like this, where you have the gut tube, which is derived from the yolk sac, and on each side of the gut tube, you can see that there is a gonadal ridge, which medially will give rise to whatever is the gonad, either testis or ovary, and laterally, we also have the development of the kidneys, whether it be pronephros, mesonephros, or metanephros, depending on which region of the embryo it belongs to. So, the primordial germ cells coming from the yolk sac cross this medial coelomic bay and enter into the gonadal ridge. And they usually reach the developing gonad by around the fifth week. Now, the reason why I call this as a coelomic bay is if you consider this urogenital ridge over here, which develops into the kidney as well as the gonad, this is a coelomic cavity, which is going to be the future peritoneal cavity. You can see that there is a bay both medial to it and lateral to it, which is part of the coelomic cavity. So this is the lateral coelomic bay and this is the medial coelomic bay. So the primordial germ cells cross the medial coelomic bay through the dorsal mesentery of the gut and enter into the gonadal ridge. And while this migration is taking place, the cells are also undergoing an extensive amount of mitosis. And this mitosis also continues as it enters into the gonadal ridge. And so there is a large increase in the number of primordial germ cells, both during the migration as well as its homing into the gonad, the future gonadal ridge. Okay. Now, once they reach the gonadal ridge, again, there is a lot of proliferation of these primordial germ cells, but as they invade the gonadal ridge, they also take along with them a layer of epithelial cells that are covering the gonadal ridge. And these epithelial cells are also derived from the mesoderm of the coelom. So this is known as a germinal epithelium. The germinal epithelium, which has got nothing to do with the formation of the eventual germ cell. So just that covering of the gonad is known as the germinal epithelium. So they surround these primordial germ cells and they form these cord-like structures which are there in the wall of the gonad, either in the testis or in the ovary. So these cord-like structures, if they cut in section, they are like small little follicles or small little structures which have got the primordial cell in the center and these epithelial cells surrounding them. And depending on the sex of the individual, the genetic sex of the individual, they develop either into the testis or into the ovary. Okay. Now there are certain factors that are involved in the migration of these primordial germ cells into the gonadal ridge. This is essentially meant for the postgraduates. If there are any in the class, I think there are some postgraduates. So first and foremost, there are cytoskeletal dynamics. This is not very important for the undergraduate students, and which includes the cytoskeletal formation of pseudopodia. So there's a large contribution of the microtubular system and the motile molecules like actin and myosin, which are found in all cells, especially motile cells. So there's a large contribution of these elements, cytoskeletal elements, which are going to be helping in the migration of these cells. Then there are adhesive molecules which will help in binding from station to station as it is migrating. And there are certain chemokines which their concentration gradient helps the cells in migrating in a particular direction. So it is the concentration gradient that will help the cell to identify which is the direction in which it is supposed to be moving. So the entire cytoskeletal element is going to be polarized in the direction of the concentration gradient, and that concentration gradient includes certain chemokines like STF1, and its receptor on the cell is usually the CXCR4 receptor. Then there are certain other factors that help in the migration of these primordial germ cells, like the seed factor, the c-KIT ligand and its receptor, which is a c-KIT receptor. Then during this process, there are certain proteins which help in erasing all the epigenetic marks in the DNA, which includes methylation, acetylation. All of that is deleted at the level of the primordial germ cell. So usually the cell that migrates is without most of its epigenetic markers. I don't say all, because there are some epigenetic markers that are retained during the process of the formation of the gamete as well. Now, in the development of the PGCs also, there are certain factors that are involved. Again, this is meant for postgraduates, not so much for undergraduates. The initiation and the activation of the genes that are meant to maintain pluripotency, for example, OCT4, the expression of OCT4 is considered as also a marker for a pluripotent stem cell, which could be also found in the bone marrow as well as in the wall of certain organs, which have the capacity for regeneration and redevelopment even after injury throughout life. Then there are certain developmental factors which are induced by the formation of the trophoblast, which helps in the formation of the placenta. For example, bone morphogenetic proteins that are BMPs, and you're going to come across BMPs a lot of molecular regulation, especially at the level of the ectoderm and the endoderm, and the differentiation, formation of the neural tube. All of that is actually guided and helped by BMP proteins. Then for the proliferation, migration, survival, there are certain factors, and also for the final differentiation of the germ cells, there are certain factors that are involved. Now, what about the timelines? As I said, the precursors of the adult gamete that are formed is actually formed when the adult that we're talking about, their mother got pregnant with that particular individual. So those gamete primordial germ cells, which are found in the testis or ovary of an adult, were actually formed at the time when their mother got pregnant. And that too in the second to third week of intrauterine life, where these cells were found in the wall of the endoblast, and from there they migrate to the wall of the yolk sac or the primordial yolk sac. In the second week, it's still the primordial yolk sac. Then from the fourth to sixth week, where the definitive yolk sac or the endoderm is formed, they migrate again to the dorsal body wall via the dorsal mesentery of the gut near the allantois. And finally, 7th week onwards, you have the induction and formation of the testis or ovary. That means the final differentiation into either of the gonad, either a testis or an ovary, depending on what is the genetic sex of that individual. And here, this differentiation is actually helped by the interaction of these germ cells with the somatic supporting cells, which are derived from that germinal epithelium, which I told you is covering the gonadal bridge. So in males, these mesodermal derivatives or epithelial cells form the Sertoli cells, which are also the supporting cells for spermatogenesis. And in the females, they form the ovarian follicular cells, which surround the oocyte which is present. Now, in the males, it remains dormant till the time of puberty. So the tubules are still not formed, so they still remain as spots. That means they are non-luminal structures. So they don't have a tube inside. So there is no lumen inside the tube till puberty happens. So during puberty, the canalization takes place, and there is the formation of the seminiferous tubules. And what keeps it dormant till puberty is also known as the male meiosis inhibitor. Okay? In females, by the 5th month, the primary oocytes form from the primordial germ cells. And these are arrested in the diploid phase of meiosis 1. And around the 5th month, there are more than 7 million such oocytes, and they all start developing apoptosis. A lot of them start developing apoptosis, so that by the 7th month, there are only about 2 million, and at birth, there are only about 600 to 800,000 oocytes that are remaining inside the ooth. And the secondary oocyte that is formed before birth is arrested after birth, is arrested at the metaphase of meiosis 2. And this metaphase 2 or meiosis 2 is only completed after fertilization. So the entire process of gametogenesis in females is only completed if fertilization takes place at all. Okay? So this figure is just a short synopsis of the entire process that is taking place both in males and females. And you can also see that there is an indication as to whether there is a diploid or an haploid number of chromosomes in that particular stage of gametogenesis. Okay? So, any doubts so far? Any questions that you want to ask? I'll just check the chat again. Hang on. Neonatal कब तक होता है? So that is 28 days. That is true. And as a matter of fact, you can understand there are a lot of customs that are related to childbirth that are completed at 28 days after birth. For example, in many of the cultures in India, it's at 28 days, after 28 days, that the baby is actually put into a cradle. Till then, the baby is always kept like a kangaroo. It's called the kangaroo mothering, wherein the baby is just kept close to the mother. It's after 28 days that the baby is actually introduced into a cradle. Any questions? Explain the second migration of EGCs. Okay, so this first migration of the primordial germ cells, I told you, was from the epiblast to the wall of the hypoblast or the primordial yolk sac. And the second migration starts after the 3rd week of intrauterine development, 3rd and 4th week, wherein it migrates from the yolk sac, from the wall of the yolk sac, into the gonadal ridge. So this takes place through the wall of the yolk sac. It crosses the dorsal mesentery, crosses the medial coelomic vein. I'll just show that to you. Hang on. The medial coelomic vein, what I was telling you over here, it crosses that and then enters the gonadal ridge. So this is the second migration. And what is the reason? What I didn't get the application of the rotational motion in embryology. Oh, so the rotational motion understanding is that the folding is mostly a passive process where the axis of the fold is going to be the least active or the least growing region, which is the endoderm. So that is why the endoderm forms the inner lining and the ectoderm, which is rapidly growing, forms the outer lining. Which is why I said that the primordial germ cells will find a region which has got the least activity, which in this phase of development is actually the hypoblast or the endoderm. Second migration, I didn't understand. Okay, what is the reason that we selected 28 days as a period, time period, duration for neonatal period? So the reason is that this is a period of high mortality and also certain developmental activities. For example, the final release of a lot of surfactants in the development of the respiratory system, the anatomical as well as the physiological closure of some of the ducts that are involved in the cardiovascular system, like the ductus arteriosus and the ductus venosus. A lot of that takes place in these first 28 days, and this is a period of vulnerability. And therefore the neonate is particularly vulnerable during this phase of development. And the initial loss of weight. So after a baby's born, there's almost a 10% loss in the body weight during this period of time, and this starts recovering by the end of the second week, and by 28 days, the baby has already started adding on weight. So there's a lot of reasons why WHO has classified first 28 days as the neonatal period, and any mortality during this phase is known as the neonatal mortality rate. And very often, a large proportion of the neonatal mortality is attributed to the developmental anomalies and developmental defects. Germ cells also have blood supply, while the cytokines or differentiation reduction factors don't affect them. Germ cells do not have a blood supply of their own. A lot of they are like epithelial cells. So epithelial cells usually derive their nutrition as well as their oxygenation for respiration from the surrounding interstitial fluid. And in the case of the primordial germ cells, it could also be derived from the yolk in the midline cavity or the yolk sac cavity, which is technically an interstitial fluid as well. Okay, so it does not require a separate blood supply, but a gonad, which is an organ unto itself, that has a blood supply which is derived from gonadal vessels. Okay, all good? Any other questions? Okay, great. So we can go on to gametogenesis now. Individual gametogenesis depending on the sex of the individual, that is spermatogenesis and oogenesis. Okay. Okay, starting with spermatogenesis. So you're going to be learning about the testis and its ductal system in detail, not only in histology but also in the gross anatomy. When you start with the anterior abdominal wall, you will be learning about all this. So the ductal system, you can see, has these coiled seminiferous tubules which open into the rete testis, which then end up in the epididymis, and the epididymis continues into the ductus deferens, and the ductus deferens eventually forms the ejaculatory duct, which opens into the prostatic urethra. Therefore, the urethra in the male is not only a genital duct, but it is also a urinary duct. So apart from being the urinary duct for the discharge of urine, the urethra is also the genital duct system, which helps in the transport of the gamete, the final transport of the gamete at the time of ejaculation. So if you take a section of the seminiferous tubules, you can see that it is a layered epithelium. So it is a stratified epithelium, and it is surrounded by certain, it has the basement membrane, and it also has certain contractile cells called myofibroblasts surrounded, which help in the mobility, peristaltic, slight peristaltic activity, help in the mobility of the cells that are produced and discharged into the lumen of the seminiferous tubules. So the mother cell for a nodule there that is providing nourishment is a certain cell, which is an extremely active cell, but it is a somatic germ cell. So this is what was derived from the germinal epithelium surrounding the gonadal ridge. And then you've got a series of mitosis and meiosis that are taking place from the spermatogonium right up to the spermatozoa. And you can see that what was initially a round cell has eventually become this tadpole-like structure as the process of cytodifferentiation takes place. Okay? So this is what the adult seminiferous tubule looks like. So this is the genital part, or what is there in the gonad, and this is the extragenital part, which is extending right up to the ductus deferens or the vas deferens. So before puberty, the seminiferous tubules are not a tubule, they are called as cords. Their have the primordial germ cells as well as the supporting cells which are derived from the germinal epithelium, which will become the future circular cells. And after puberty, the tubule forms and spermatogenesis starts, such that from the spermatogonia, eventually we get the mature spermatozoa. Okay? So essentially in the seminiferous epithelium, we've got two basic cell types. One is the proliferating cell, which are spermatogenic, and the non-proliferating cell, which is a supporting cell or the Sertoli cell. So their cell type, if you look at their complement of DNA, the spermatogonia type A has 44XY and type B is also 44XY, so that means it's a diploid cell. It's a diploid cell. Okay. The primary spermatocyte is also a diploid cell, and this initially undergoes duplication of the DNA and undergoes meiosis 1, so that you get a secondary spermatocyte which has got either 22X or 22Y. And this is usually haploid but 2N. And once the spermatid forms, that is after meiosis 2 is completed, now we get haploid and 1N, that is 22X or 22Y, which is going to be in the mature spermatozoa. So the process of spermatogenesis is called spermatocytosis, where the primary spermatocyte is formed from the spermatogonia. Then you've got the meiosis 1 and 2. And finally, the cytodifferentiation is known as spermiogenesis. Now you can see that one very peculiar feature of spermatogenesis is that from the spermatogonia onwards, you can see that the cytokinesis or the separation of the cytoplasm of these cells that are undergoing mitosis is never complete. So all these cells and their progeny are continually connected to each other by cytoplasmic bridges, which means that a cohort of daughter cells from one spermatogonia is always going to be in phase with each other. That means all the factors and all of them are going to be acting simultaneously and in the same phase of development. Which is why these cytoplasmic bridges become extremely important, so that all of them develop together with the same kind of chemical or cytokine influences that are occurring simultaneously. So these cytoplasmic bridges are maintained right till the very end, where the spermatozoa are released into the lumen of the seminiferous tubules. So you can see that once from a single type A spermatogonia, you can have multiple type B spermatogonia, which eventually start having meiosis. So that means here from one type B spermatogonia, you can have primary spermatocytes that are formed by mitosis, and then on you've got meiosis 1 taking place over here, and then meiosis 2 taking place over here, such that you get that haploid spermatozoa or spermatid that is formed over here, and the cytodifferentiation reduces the amount of cytoplasm, condenses the nucleus, and arranges the cell in such a way that it starts resembling a tadpole. And this entire process is known as spermiogenesis. This process is known as spermiogenesis, where from the spermatid you get the mature spermatozoa. Now, what all are involved in the spermiogenesis? You've got the formation of the acrosomal cap, which is formed just distal to the nucleus, the condensed nucleus. There is condensation of the nucleus, which forms the end of the tadpole. Then there is a formation of the neck, which is by the separation of the centriole. So one just lies close to the nucleus and the other one lies slightly distally, and this distal centriole is the one that forms the basal body for the flagellum of this tadpole. And Between the two centrioles, we get the middle piece, and this middle piece is surrounded by mitochondria, which helps in providing the energy for the motility of the spermatozoa. Okay, so this is a structure, and this is the formation of the spermatozoa from the spermatid. And all this excess of cytoplasm is shed. And the excess of mitochondria, the excess of all the cytoplasmic organelles, they're all shed off. And what is produced is an extremely condensed and efficient, which is extremely efficient in its energy consumption as well. So this process is known as spermiogenesis. You are supposed to learn the structure of the adult sperm, and this process of spermiogenesis is also something that is frequently asked. And if you look at the electron microscopic structure of the sperm as well, you can see that the end piece is called the 9+2 doublet, which is there in the axoneme. And then in the principal piece, you've got some amount of the fiber, but again, you've got the 9+2 arrangement, which is typical of any flagella. And in the area of the middle piece, you can see the mitochondria that are surrounding the basal body of the flagellum, which is derived from the centriole. And then further on, you've got the nucleus and the acrosome. The acrosome is derived from the Golgi apparatus, and that is why once it is condensed, it becomes extremely electron dense, which is why it appears black in color. Okay, so that is the structure of the mature sperm. This I've already told you, the steps in spermiogenesis, which is the formation of the spermatid first and foremost, which is after the completion of meiosis II, the formation of the acrosome, the condensation of the nucleus, the formation of the neck, middle piece, and the tail, and the final shedding of the excess of cytoplasm as the residual bodies. And a lot of the residual bodies are actually phagocytosed by the circulating cell. So the formation of spermatozoa are almost 300 million are formed per day. Now, this is important. What is the duration of spermatogenesis? This is important because when you're in the clinic, particularly a fertility clinic, you will come across men and women who've got issues with fertility, obviously. And for various reasons, there may be some cause for infertility that is a modifiable cause for infertility in the male. For example, there may be a man who comes to you in the clinic and you examine and see from the sperm cup that the person has got oligosperm. And when you examine them and you talk to them, you find out that they have this habit of wearing tight clothes, that is tight underwear as well as tight jeans or tight trousers or whatever. Now, the reason tight clothes have an effect on spermatogenesis is that usually the testes are held away from the body so that they can be maintained at a lower temperature than the body temperature, and this 2 to 3 degrees of difference in the testicular temperature and the body temperature is essential for spermatogenesis. So a person who wears tight clothes affects the temperature regulation of the testes, and therefore that can affect efficient spermatogenesis, and that is why the person may be oligosperm. Similarly, a person may have varicocele, which is a dilatation of the veins around the testis, and it is the venous system which helps in maintaining a lower temperature. So there is a counter current exchange between the arteries and the veins, which helps in bringing down the temperature. And this mechanism is affected by a condition, a pathological condition known as varicocele. So you also perform a surgery for correcting the varicocele. Now, when you are dealing with a patient like this, you must understand that the process of spermatogenesis till the release of the mature spermatozoa takes about anywhere between 60 to 80 days. So depends on which book you're referring to. It could be 64 days to 74 days. So any effect of a treatment for fertility or an intervention for infertility, the patient should not be told that he's going to become fertile the very next day after that procedure has been performed. For example, the person starts wearing loose-fitting clothes. One can expect the fertility to come back to normal if that was the cause for the infertility after about 2 to 3 months. So this is something that the patients need to be warned about, because the duration of spermatogenesis, for adequate spermatogenesis to start as a new process from the point of intervention would be about 60 to 80 days. Okay, so this is important, and the reason why there is a range that I'm telling you is that depending on the book that you're referring to, for example, Langman says that the first meiotic division lasts for about 22 days, whereas Larson says that it actually lasts for 8 days. So depending on which book that you're referring to, the range of days may be variable, and that is why you must definitely warn your patients that any intervention for infant fertility will not have a large effect before 2 months are over at least. Okay, so that's why this timeline and the duration becomes important for you to know as well. Okay. Okay. Now coming to oogenesis, the process is the same, except that most of the process is actually taking place in the intrauterine line, whereas in the males, the spermatogenesis is actually a post-pubertal or a pubertal process. Okay. Now, the essential process is the same. Mature gamete is always going to be haploid 1N, as you see with the spermatids as well. So what's the difference? So the timelines are completely different. So in oogenesis, most of the process of oogenesis is actually completed in intrauterine line itself. So the primordial germ cells, they cross the gonadal ridge, and when they cross the gonadal ridge, they are also covered by a layer of these epithelial cells, which are derived from the germinal epithelium, covering the gonad or the ovary, and they form small, tiny follicles. And these follicles are known as primordial follicles. So you've got the germ cell surrounded by this flat epithelial cells. They're all separate epithelial cells. There are no bridges between them, alright? So they're separate epithelial cells that are surrounding them. And these are undergoing mitosis not only during the time of migration, but also after reaching the gonad. There is an extensive amount of mitosis that takes place, and all the daughter cells of mitosis are also covered by follicular cells or the germinal epithelial cells. Okay. Now, so by the time it reaches the 5th month of intrauterine life, as I told you, the differentiation into the ovary has already started. Okay, and whichever primary oocytes survive by about 5th month of intrauterine life, they actually enter into the first meiotic division, and there they are arrested in the diploidine of prophase 1. Please remember this, the diploidine of prophase 1. So this is the stage in which the primary oocyte is arrested. Okay. Now, in the prepubertal ovary, you have that cuboid epithelium that is surrounding the ovarian tissue, and that is known as germinal epithelium, though it does not give rise to any germ cells. Then there is a cortex, and there is a medulla, which is essentially filled with all the blood vessels and nerve plexuses. So what you see near the surface are a lot of these primordial follicles, which are the oocytes that are surrounded by squamous follicular cells. And they are when we see a child or a female child or a female adult, most of them are going to be primary oocytes in prophase, diploidine phase or prophase 1. And these follicular cells, they maintain the oocyte in this phase with the help of a factor which is known as the oocyte maturation inhibitor. So till there is another influence that is coming from an external source, these oocytes are maintained in that phase, and they can remain in that phase for almost 40-45 years till the woman becomes menopausal. Okay. So what about the time? So at about 5th month of intrauterine life, I told you that the ovarian differentiation is usually complete, And at that point in time, there are almost 7 million oocytes that are present in the developing ovary. And by about the 7th month of intrauterine life, so after that 7 million, a lot of apoptosis starts. Apoptosis is programmed cell death. And by the 7th month, so within about 2 months, this number comes down to about 2 million. So what remains at the 7th month of intrauterine life, you have only about 2 million of these follicles that are remaining, which contain a primary oocyte. So this apoptosis continues. So by the time of birth, in the ovary, there are only about 600 to 800,000, some folks even say 1 million primary oocytes which will be present. And this continues to decrease in number till puberty. So that means the process of apoptosis, which starts at about 5th month of intrauterine life, continues right throughout life, both prenatally as well as postnatally. So in the pre-pubertal period, there is a further decrease in the number of these follicles containing the primary oocyte. And by about the time a girl enters puberty, there are only about 400,000 to 600,000 that are remaining in the ovary. And during the reproductive phase of the woman, that is from puberty right up to menopause, about 400 odd ova may be ovulated into the peritoneal cavity. That means during each menstrual cycle or each ovarian cycle, one ovum usually is only released into the peritoneal cavity. Okay? And of these also, only those ova that are fertilized are ever able to complete the entire process of meiosis II. Okay? So what is this follicle? It's the composite unit of a primary oocyte that is surrounded by follicular cells. And at the time of puberty, under the influence of FSH and NH, the follicular inhibiting factor, the factor that I told keeps the oocyte from maturing, that is actually counteracted by the follicle stimulating hormone, which is released by the anterior hypophysis or the anterior pituitary. I prefer using the word hypophysis, which will come later on during your course with us. But so far, since you are more familiar with the word pituitary, I would prefer using the word pituitary for you right now, since this is your first class related to it. In school, I know that you're all familiar and used to using the word pituitary, which is not a very appropriate term. So the appropriate term for addressing it is actually the hypophysis. The anterior hypophysis releases the follicle stimulating hormone as well as the luteinizing hormone. And during each ovarian cycle after puberty, there is a cohort of these follicles that are stimulated by the follicle stimulating hormone. And just before ovulation, there is a surge of the luteinizing hormone, which helps in determining which is going to be the dominant follicle and which is the follicle that is going to be ovulating. Okay? So the primary oocyte is surrounded by flattened follicular cells, and this is known as the primordial follicle. Next, what happens is that the primary oocyte, the follicular cells, they start becoming cuboidal in nature when they get stimulated by the follicle stimulating hormone. A very important point that you must understand is that the basement membrane of this epithelium, which is formed by the follicular cells, is lying externally. That means towards the ovarian tissues. This is the basement membrane that is formed on which the follicular cells are resting. So if you see in a late primary follicle, so in a primary follicle, the cells become cuboidal in nature, and you can see that in a late primary follicle, the epithelium also becomes stratified. So it becomes a stratified cuboidal epithelium, and you can see that this is the basal membrane Please do not confuse this with this dark pink lining that is surrounding the oocyte, primary oocyte. This is known as a zona pellucida, which forms as a glycoprotein membrane that is surrounding the oocyte, and this is actually secreted in collaboration between the follicular cells as well as the primary oocyte. So the zona pellucida is a product of both the follicular cells as well as the oocyte. So this is the zona pellucida, and this is not the basal membrane for the follicular cells. Please understand that the basal membrane for the follicular cells is actually found over here. This is the basal membrane of the follicular cells. Okay. Yes, the zona pellucida does form in the primary follicular cell. The late primary follicle will have a clearly defined zona pellucida. Okay. And as I said, the zona pellucida is also secreted in collaboration between the follicular cells as well as the oocyte. Similarly, there are cytoplasmic bridges in the form of microvilli which cross between the follicular cells and the oocyte, and that helps it again maintaining nutrition and providing hormonal factors in the further development of the oocyte. Okay. Now, what happens next? So this is what I was saying. There are microvilli that connect the oocyte with the follicular cells, which cross the zona pellucida, which helps in exchange of essential material, both nutritional, oxygen, as well as hormones, which help in the maintenance of that and the development of that particular oocyte. Now, whenever there is a large number of cells coming together, that means you can understand that nutrition is going to be compromised, and therefore, very soon, in the stratified cuboid epithelium, fluid-filled spaces start appearing, and the moment these fluid-filled spaces appear inside the follicle, it is called as a secondary follicle. And in an early secondary follicle, you can have multiple fluid-filled spaces, which help in providing nutrition not only to the follicular cells but also to the ovum, the oocyte, the primary oocyte. In the late secondary follicle, all these fluid-filled spaces, they start coalescing, or they start coming together, and they form one common cavity, which is known as the antral cavity, or the follicular antrum. And you can see that by the formation of the follicular antrum in the late secondary follicle, the ovum starts getting pushed to one side where it is surrounded by its own collection of follicular cells. Okay? And you can understand that this has improved the exposure of the follicular cells to the nutrition-rich antral fluid. So this structure, where the ovum is surrounded by the follicular cells, is known as the cumulosophorus, or the gill that contains the egg. The egg containing gill. Okay. Yeah. Now you can see that there is ovarian tissue that is further surrounding the follicle and around the basal membrane of the follicle, and this is known as a theca. The theca, which is cellular on the inside, which is known as theca interna, and more fibrous on the outside, which is known as theca externa. And this theca is an extremely vascular structure like any endocrine organ, and the vascularity of the theca helps in providing nutrition to the follicular epithelium as well as to the ovum. Okay. Yeah, so this is the theca externa, where you can see that there is a lot of blood vessels, and this is the theca interna, which is essentially, again, has blood vessels, but it is predominantly more cellular than the theca externa, which is more of fibrous. Okay. And the theca and the follicular cells also form an endocrine unit. They help in regulating certain secretions of hormones which are produced by these follicles. Which cells are you referring to? Manit has asked this. Yeah, theca interna cells are derived from the ovary or the ovarian mesoderm. the ovarian cells which are already found in the ovarian cortex. So they are derived from the ovarian mesoderm, okay, which are surrounding the follicles outside the basal membrane of the follicular cells. And they are all connective tissue or mesoderm derived cells. Whereas the theca externa is essentially fibroblasts, mainly fibroblasts and blood vessels. Okay. Alright. Now, coming to the developing oocyte again. So as the oocyte is developing, it starts enlarging and it develops a whole organelle. Particularly, there is an increase in the number of mitochondria, and the ER or the endoplasmic reticulum also starts increasing in size. Okay, and as I said, that the primary oocyte is actually arrested in the differentine of meiosis 1. It is only at the time of the stimulation of the follicle or the cohort of follicles that are selected in every ovarian cycle that the primary oocyte, which is arrested in prophase, differentine or prophase 1, actually enters into meiosis 1, completes meiosis 1. Then the secondary oocyte that is formed is later arrested in metaphase 2. So that arrest happens, and then the ovum is discharged into the peritoneal cavity as secondary oocyte. So the secondary oocyte is arrested in metaphase 2. Okay? So from differentine or prophase 1 to metaphase 2 takes place during a specific ovarian cycle. And how many will be selected? So in a cohort, you can have anywhere between 15 to 20 follicles that are selected, out of which only one of them becomes a dominant follicle usually, unless you're using some stimulatory hormones to stimulate the ovulation. Yeah. So the dominant follicle is also known as the Graafian follicle. And the Graafian follicle is got a very typical structure. It can go up to almost 2 to 2.5 centimeters in size, that is in diameter, and it is found on the surface of the ovary. It can be easily identified not only with an ultrasound but also during laparoscopy. So when they're harvesting an egg in a woman who is going in for in vitro fertilization, the development of the Graafian follicle is monitored with the help of ultrasound, and finally it can be harvested with the help of either the ultrasound guided a needle or during a laparoscopy, wherein you put in a camera assisted needle into the peritoneal cavity and derive the egg from the dominant follicle. Okay, so that is how the Graafian follicle works, and where it projects or thins out the ovarian wall on the surface of the ovary, that is also known as stigma. It's also known as a stigma. Okay? And with the increase of hydrostatic pressure and the thinning of the wall at the time of ovulation, the walls rupture and the ovum is released into the peritoneal cavity. Okay? So this is what you can see as a rupture of the follicle into the peritoneal cavity, and then as this ruptures, you can see that the theca is also ruptured, and therefore the blood vessel is also ruptured, which is why there is hemorrhage into the follicle, and that is why this is known as the corpus hemorrhagicum after ovulation is taking place. And very soon these follicular cells, they get converted into lutein-filled cells. That means there is this pigment, this yellowish fatty pigment that is developed as these cells enlarge, and that forms the corpus luteum, which releases a lot of progesterone, which helps in the maintenance of early pregnancy if fertilization takes place, and also helps in maintaining thickness of the endometrium in the secretory phase of the menstrual menstrual cycle. And this corpus luteum has got a definitive lifespan. It usually lasts for about 7 to 10 days after ovulation, after which it starts regressing. And that is why once production of progesterone decreases due to the involution of the corpus luteum, the thickened secretory endometrium is not supported by the hormones and it is shed off on the 14th day after ovulation. So the menstruation that takes place is because of the involution of the corpus luteum, which is responsible for the release of progesterone. If fertilization takes place and pregnancy happens, then the corpus luteum remains for a slightly longer time till the placenta can thicken and start releasing the gonadotropins as well as the progesterone, and then that is also known as the corpus luteum of pregnancy, which stays for a longer period than the regular menstrual corpus luteum or the ovarian cycle corpus luteum. Okay? So these hormonal levels and their control of the process of ovulation and the development of the oocyte, you're going to be dealing with in greater detail in physiology. The Eden surge, which is extremely important prior to the process of ovulation. Okay. Now, when the ovum is released, it is a large cell. It's almost 0.1 millimeter, 0.1 millimeter in size, a millimeter in size, 1 to 2 millimeters in size. It has the zona pellucida, which is intact, and this becomes extremely important because the fertilized ovum is an extremely sticky cell, and the zona pellucida prevents it from sticking anywhere and everywhere. And the cells of the cumulus ovorus, they form about 2 to 3 layer thick follicular cell covering around the zona pellucida, and there is a space between the ovum, the cytoplasmic membrane of the ovum, and the zona pellucida, and this is known as a perivitline space. So normally the polar bodies which are released at the time of the first meiotic division and the second meiotic division, they lie in this perivitline space and usually become apoptotic and can be lost. Sometimes they may persist. So this I've already told you about the formation of the corpus. Hemorrhagical. Middle schmerz, you're again going to discuss more in physiology. Get over there. The formation of luteum and the secretion of progesterone by the luteal gland, and how it maintains the endometrium during the secretory phase of the menstrual cycle. Eventually the corpus luteum regresses, as I told you, and it remains active if the person is pregnant till about 12 to 16 weeks, when the placenta kicks in as the fetal-maternal endocrine unit. Now, what are the timelines for oogenesis? This is what I told you. This is important for you as well. So from 12 weeks to 5 months, there is a formation of the primary oocytes, and the N can be as much as 7 million by the end of the 5th month. There is a Wittlein membrane. Okay, what do you understand by the Wittlein membrane? Wittlein membrane is the plasma membrane of the. This is the ovum. Okay, so the ovum contains yolk. So the membrane covering the yolk is the Wittlein membrane. So the plasma membrane of the oocyte or the ovum is known as the Wittlein membrane. So the space around. Sorry. Roshan Teja needs to mute himself or herself. I don't know. Yeah, so Alpana Kumari. So this is the egg or the ovum, and the cytoplasm of the ovum is the yolk, and that is why this is the Wittlein membrane or the plasma membrane of the egg is the midline membrane. So this is the perimidline space. Okay? And then surrounding the perimidline space is going to be the zona pellucida, basins and zona pellucida. Can the term secondary oocyte of ovum be used interchangeably? Yes, they can be used interchangeably because at the time of ovulation, what is released is actually a secondary oocyte. Is a secondary oocyte, but it is arrested in meiosis 2, in the metaphase of meiosis 2, which is only completed at the time, at the formation of the otid, like the spermatid, can only take place after fertilization. So what is essentially released at the time of ovulation as the ovum is technically is a secondary oocyte. What could be the purpose of first making this many primary oocytes and then regress them? What is the purpose? The teleology of this, the purpose is actually not known. It's considered to be the precious gamete, especially in mammalian reproductive physiology. The ovum is a precious gamete, and a large number of it is actually produced before birth, and all of them are actually exposed to the immune system, and they are considered as cell. And whenever it is released into the peritoneal cavity, it is never recognized as a foreign antigen. Whereas the spermatozoa, on the other hand, it is a non-precious gamete because it is produced in billions, and eventually it is only 1 out of the 10 million or so, or 100 million spermatozoa that are released in an ejaculate that may be successful in fertilizing an ovum. So why specifically the female gamete is a precious gamete? Probably also because it is a cell that is kept arrested, metabolically arrested, and so there's very little activity, so its genomic framework is also relatively maintained with as little change as possible from the very beginning. The problems with a late gametogenesis, as what happens in males, is that every cell that is produced as a gamete in the males is not recognized as a self cell by the body. So all of them are considered as foreign cells, and that is the reason why there is a very definite blood-testis barrier that is formed in the testis to prevent the exposure of the foreign antigens that are there in the developing spermatozoa, so that they are not exposed and they are not destroyed by the immune system of the body. So Gautam Kapoor says to enhance the chances of sufficient gametes to remain when they are required. But that doesn't actually quite answer the question. What causes an ectopic pregnancy? There are multiple reasons for ectopic pregnancy. A, if the motility of the ovum is hindered, and B, if the zona pellucida is leaky and does not form adequately. As I told you, zona pellucida is something that prevents it from sticking into unnecessary places. So usually the hatching out of the zona pellucida takes place about the 5th to 6th day. By the time the fertilized ovum would have reached the endometrial cavity of the
your video call, then the screen is black.
Hello?
Good evening, sir. Good afternoon.
Am I audible now? I'm sorry, there was a problem with the connection.
Yes.
Sir, you are on.
Sir, I'm audible, but not audible.
Alright, sure. That's alright. There's a problem with the connection, so I'll just figure that out. And can we continue?
Yes, sir.
Alright.
Sure.
Yes, yes, I can. Alright. I'm sorry about that. There was some glitches in yeah, so there were some questions there. I'm sorry. Yeah, so I was talking about ectopic pregnancies. So if you're so Deepika, can you please mute your audio? Deepika, please mute your audio. Thank you very much. Alright. Yeah, so you asking about ectopic pregnancies. So if the zona pellucida and the hatching takes place, or zona pellucida is not formed with and the hatching takes place before the ovum reaches the endometrial cavity, it can stick to the walls wherever it is, and therefore, particularly if there is a blockage in the tube as well, so it can get implanted in the tube, and that becomes a site of implantation which is not normal, which is why it is known as ectopic, okay, outside the normal topology. Deepika, please mute your audio. Can Deepika hear me? Thank you. All right. And another reason why ectopic can take place is, particularly in our country, tuberculosis is a very common condition, and especially in the rural as well as poverty-stricken, as well as in other setups as well, there is a tendency in our country that we let our children roam around naked, especially infants and small children. They roam around naked, and many women usually have had silent tuberculosis of the pelvic organs, and tuberculosis has a tendency of distorting any structure because of fibrosis, and in such conditions the tubes can also be distorted and their lumen can be obstructed. So even if everything was normal, if the ovum is not able to go beyond a constricted fallopian tube, it can remain stuck inside the fallopian tube, and the process of hatching from the zona pellucida can also take place inside the fallopian tube, which will also give rise to an ectopic pregnancy. So the causes for ectopic pregnancies are many. It could be because of fibrosis inside the pelvic cavity of the woman. It could be because of a distorted or an abnormal zona pellucida. It could be various causes. Alright, so to answer the question on the ectopic pregnancy, you are again going to be dealing with this after fertilization and implantation, which will happen later. Okay? I hope that answers your question. Alright. Next, yeah. Now, gametogenesis can also give rise to certain problems. So there can be problems that happen during gametogenesis which can give rise to defective gametes. Now, most of these usually either happen because of non-disjunction of the chromosomes, and you can also have these non-disjunctions and problems taking place during meiosis, or even during mitosis of the early embryo. That means when that initial zygote is formed, while the zygote is undergoing multiple mitoses to form the embryo, there can be problems of separation of the chromosomes such that there can be a population of cells which is called either monosomy or trisomy or isotysomy or something of that nature, taking place in a cohort of cells, not in the entire organism or the entire individual. And therefore, the syndromes that are there found in an entire individual can also be localized to specific areas depending on how extensive that mosaic is. Okay, so all these problems can occur during gametogenesis or even later on during the mitosis of the zygote. So some of the common syndromes that occur due to non-disjunctions. So about 50 to 80% of the abortions that take place or miscarriages that take place within the first trimester itself are usually because of chromosomal anomalies. Some of them are able to survive and are born. Many of them are aneuploid, and the commonest among them are usually trisomies. Monosomies are usually incompatible with life. So most of the monosomies are actually aborted early on itself. There are some rare, there is only one example of monosomy that usually survives, and that is the monosomy of X, which is known as Turner syndrome. Again, a lot of these genetic disorders you're going to be discussing in your class of genetics, where you're going to be discussing about the heredity and various different kinds of patterns of inheritance and certain congenital genetic abnormalities like this Turner syndrome, Klinefelter syndrome, and so on and so forth. So this over here is, you can see from the karyotype, is a trisomy of the 21st chromosome, which is very often called as Down syndrome. So the reason why they call it as a syndrome is that this association, or this trisomy of 21, is associated with a pattern of physical as well as mental features and possibilities that can be identified specifically as the Down syndrome. That is the reason why it is known as a syndrome. And it occurs universally, and all the children that are born with trisomy 21 have got a similar physical as well as mental attribute. So these are the features that you can see in trisomy 21. Now this can also occur because of translocation in during the time of meiosis, especially a translocation between 14 and 21, so that even if you are only in the karyotype, you only see 21 copies of 21, there will be a third part of 21 that may be stuck on chromosome 14. The reason being that during the process of meiosis, there is usually a clustering of certain chromosomes, and 13, 14, 18, and 21 have a tendency to cluster together during the entire process of mitosis and meiosis. That is the reason why there is a possibility of a translocation between 14 and 21. Okay. For example, this is a case where you have got a normal 14 and a 14 with a small bit of a 21 as well. And that is why this also is a trisomy of the 21, which will have the same features as Down syndrome or trisomy 21. So even if you can see that the karyotype only has a normal disomic 21. Okay. There are certain others that are rarer, and for example, you've got the trisomy 18, which is known as Edward syndrome. A further rarer one is Patau syndrome, which is trisomy 13. And the only monosomy, as I told you, that survives is the Turner's, which is an XO, where there is only one X chromosome in a female. And all of them have got a very specific physical characteristic, mental characteristics, and clinical features by which they can be identified. Again, you're also going to be learning about these microdeletions in your class of genetics. One of the commonest, the second common cause after trisomy 21, the second commonest cause of mental retardation because of a genetic defect is actually the Fragile X syndrome, which is found in men where there are certain CGG repeats in the X chromosome which become reduced. So normally there are about 200 to 250 CGG repeats, and in a person with Fragile X syndrome, these are reduced to about 45 to 60. And so there is a tendency for there to be breakages in the X chromosome, the single X chromosome, which is found in the males, which makes them more susceptible to a certain syndrome, which is very commonly associated with mental retardation. And okay, so these syndromes, as well as imprinting, which is related to the Prader-Willi syndrome and the Angelman syndrome, are also going to be dealt with in your genetics classes, so please pay attention over there, and you are supposed to know their physical as well as other diagnostic characteristics. You should be also be able to identify these when you are shown a picture of these specific syndromes, okay? Because their physical characteristics are very typical and can be identified by just looking at the baby, okay? Now, coming to contraception, this is also going to be dealt with in your class on fertilization, because technically contraception is the prevention of fertilization. So you have multiple methods of contraception. You've got reversible as well as irreversible methods. So reversible methods could be natural, of which the commonest is absence, the rhythm method, wherein one knows approximately predicted the time of ovulation and prevent having sex during the period during which there is a high possibility of a fertilization taking place. Then there are some people that practice coitus interruptus. That means they interrupt the sexual intercourse at the time of ejaculation, but this is an extremely unreliable method of contraception, because even the pre-ejaculatory fluid can contain spermatozoa, and just one spermatozoon is more than adequate for fertilization if it has to happen. Okay. Then there are barrier methods which are reversible both in the males as well as in the females. So in the male you can have the condom, which covers the fetus and prevents the ejaculate from entering into the female genital tract. And there can also be condoms which are also associated with the spermicide, so just in case there is any leakage of the sperms or the semen from the condom due to either micro tears or breaks, that can also have a secondary barrier in the form of sperm site, which are able to kill off all the sperms. In females also there are barrier methods like the condom. There is a female condom that can be worn inside the vagina, diaphragm which covers the cervix, the cervical cap. There can be sponges that are inserted into the vagina, which can contain spermicides, again with the purpose of killing off and preventing the sperms from entering into the uterine cavity through the cervix. Then there can be medicated vaginal rings, again which contain spermicides, and intrauterine devices like copper T and the loop, they kind of instill a state of a pseudo pregnancy which prevents further pregnancies from taking place, but the copper is also supposed to be acting as a spermicide, or so it is believed. Then among the reversible methods, you also have endocrine methods. For example, the contraceptive pills, like you can have the OCPs that are usually prescribed by the health worker to adult females to prevent pregnancy. You can have estrogen or progesterone depots, and in the males, there are certain experimental contraceptive hormonal methods that have come up, but they're not yet completely applied in clinical practice as yet. Okay? And there are certain morning after pills also, wherein after having unprotected sex, or there is a risk of pregnancy after having unprotected sex, the person may take a pill which induces an abortion just in case a fertilization has taken place. Okay. Then you've got irreversible methods, which are usually surgical. Again, you can have both in the males as well as in the females. So in the males, you have the vasectomy or the ductal blocks, which will prevent the sperm from entering into the urethra, the prostatic urethra, and thus what comes out as an ejaculatory fluid at the time of intercourse is a sterile fluid which is completely devoid of any spermatozoa. Okay. And in the females as well, you can have surgical interventions which are irreversible, like the tube ligation. But there are some centers in which the tube ligation can also be reversed, because there are sometimes women who come after a second or third marriage, wherein the husband insists that they should make a baby of their own, and so if the woman is already had a tube ligation during a previous pregnancy or after a previous pregnancy, some of these women want to get the tubes recanalized so that they can become pregnant with the new partner again. And the same thing can also be done after a vasectomy. There are some people who do vasectomy reversals as well, but the chances of complete return to fertility are not that great as you can see with a tubal ligation reversal. It all depends on how much fibrosis is there and how much of the sperms are able to, and the tube is able to maintain patency so that they can have a natural birth. Otherwise, you can always go for an in vitro fertilization. Okay, so that is about the contraception, which again we will be dealing with in detail in your class on fertilization. Okay, so that is I think the end of today's class. That's the summary. You're supposed to know about spermatogenesis and oogenesis primarily. You should know about the primordial germ cells and the migration and how they progress into the gonads and how they develop further. And finally, a note on contraception and the abnormalities of gametogenesis, particularly related to discoidy and non-disjunction. So, any further questions? Why are gametes considered foreign cells? Not all gametes, only the male gametes. So in males, as I said, spermatogenesis is kept in limbo or arrested till puberty. And you know that the thymus, which is a center for cell-mediated immunity, is responsible for recognizing all lymphocytes that can respond to a self-antigen. So what the thymus does is that whenever there is a self-antigen that is recognized, it is killed off, right? So that means by the time a person reaches puberty, the thymus is already involuted. So that means as far as the immune system is concerned, every cell, every antigen on a cell has been exposed to its lymphocytes, and those lymphocytes have all been culled or killed off. So by the time spermatogenesis starts at puberty, the thymus is no longer there. So that means you know that meiosis that is involved in spermatogenesis is also associated or always associated with crossing over at the phase of the chiasma formation in meiosis 1, right? And so this reorganization of the genetic makeup, which happens during the chiasma formation, leads to also a change in the antigenic presentation of that particular cell. That means for all practical purposes, every spermatid that is formed is a new foreign cell, which is why it needs to be isolated from the immune system. Because now, if an immune cell or a lymphocyte sees or recognizes a spermatid, it will recognize it as a foreign cell, which is the reason why mumps, which is an infective parotitis or viral parotitis that happens usually in childhood, no problem. But if mumps happens after puberty, a very common association of mumps is an orchitis. So apart from a parotitis which happens in the parotid glands, mumps can also be associated with orchitis, which is testicular inflammation. So whenever testis is or any organ or any structure is inflamed, there is a breakdown of vascular permeability. That means if there is a tight barrier, that barrier has a tendency to break open. And then what happens is that all the spermatids that have so far been kept isolated from the immune cells, they get exposed to the immune cells, and the immune cells recognize those spermatids as foreign, and they mount a reaction to the spermatids, and therefore they produce a complete destruction of the testis. And that is why a person who has mumps after puberty has a very high tendency of being infertile or sterile, because they actually become ageospermic if both testes are affected. So that is why in males, the involution of the thymus and the commencement of spermatogenesis are usually aligned in such a way that one ends and the other starts, which is why there is the formation of the blood-testis barrier, which is also aided by the Sertoli cells and prevents the exposure of the newly formed spermatozoa, which are technically foreign cells, from getting exposed to the cells of the immune system. Okay? Any other questions? But crossing over also occurs during ovum formation. No, but most of the oocytes have been formed before birth, all the 7 million, so all of them have been exposed to the thymus. There is all the oocytes in all the stages of development are no longer a new cell. So they've all been exposed. So the formation of the primary oocyte cell and the secondary oocytes, all of that is taking place within the intrauterine life itself. Therefore, all of them have been exposed to the thymus, and therefore they are recognized as self. You mentioned stratified epithelium in in seminiferous tubules. Is it layered simply because of the layer of developing stages of spermatocytes? Yes. Yes. So therefore, when you look at it, it actually resembles a stratified cuboid epithelium. But technically, if you just look at the seminiferous tubules as a collection of Sertoli cells, then it's a simple columnar epithelium. Can a baby with XXO sex chromosome survive? Over there you already have double X, then there is no problem with that. Unless it's a mosaic, where there is a certain cohort of cells that has got XO and another cohort that has got XX. What is different from the ones we studied? I don't understand.
No, sir, I was just clarifying about that stratified one that you told that technically it's simple epithelium. That's what we had studied, so now it's clear.
Yeah, so if you only look at the Sertoli cells, it's a simple columnar epithelium. At the most,
Yes.
you can call it as a pseudo-stratified epithelium. But with this with a post-pubertal seminiferous tubule, it appears like a stratified tubule. Okay.
Yes, I
Then even if the testis gets affected once, can't the cycle of spermatogenesis start again freshly because primordial germs are still remain and aren't they cell? Yes, so that is a possibility if the blood testis barrier reforms. If it does not reform, then it will not happen. So that depends on the level of disruption that occurs with the viral infection. Okay. Any other questions? So I'll be posting this on your Saran platform and you can access that, and your reference textbook is Landman's, but otherwise you can check anywhere and everywhere and you can keep checking back with us, and if you have any doubts, please do. If I'm able to answer your question, I will provide you an answer, or I'll look up for an answer. If not, you can provide the answer yourself. Okay? Thank you very much. Have a nice afternoon and have a good weekend.
Sir, is there a difference between the South Asian and international edition of Langland?
I am not familiar with South Asian edition. I have only used the international edition. I'm not really familiar with it. I'm sorry, I cannot answer that question.
Thank you.
See, the reason why we recommend Langman is that it's just got enough information for all of you. Just adequate for an undergraduate level, and the things that are there in the purple boxes or the green boxes can be avoided if you're not particularly interested. So those are good to know. The problem with a lot of the Indian authors as well as other textbooks is that the amount of detail is just too much. And you probably don't need as much detail at this current phase. If you want to learn more, go ahead, learn. No one is going to stop you from learning more. But at the level of evaluation, you really don't need so much of details. Okay? Which is the latest edition. I am using the 12th edition. So again, I am not too familiar because I usually check a lot of things that would be around me. Okay? And personally, I don't like Langman because again, at my level, there is very little information in Langman. But then I have to, when I'm teaching you, I need to provide you at least the information that's there in the background, because I'm not too sure how many of you got access to that. The whole of a somatic body contains the same antigen, or it depends? Every cell has got a different antigen spectrum. Every cell. The neurons will have a completely different antigenic spectrum compared to what gut epithelial cell would have, or pulmonary epithelial cell is going to have, or a skeletal muscle is going to have. That is how they are able to perform immunohistochemistry, where we can specifically target an antigen on the surface of the cell and visualize it. So each cell, when it differentiates, the expression of proteins on its surface or in the cytoplasm or in its nucleus is changed. That is what differentiation does. So a pluripotent or a totipotent stem cell has certain expression, and it has a certain form, and once it differentiates under the influence of certain factors, then certain genes are kept quiet, some genes are overexpressed, and depending on what is expressed, the entire protein manifestation and the glycoprotein manifestation, changes. Which is why a neuron is so different from an alveocyte or a pneumocyte. Even though they are coming from the same zygote. Both of them have developed at the same zygote, but their physical form, their chemical composition, their protein expression, everything is different. Anything else?
Sir,
Yes,
when trisomium takes place, what the problem is there? The active protein formation or what?
It depends on the syndrome that we're talking about. So there are with specific trisomies. If there is an overdose of the expression of certain genes, that is associated with the physical manifestations. For example, in trisomy 21, there's a physical manifestation that is associated with that extra usage of that particular chromosome. So in all of them, the mechanisms are very, very different, and therefore it's very difficult to say that there is a common method of excess dosage which happens. For example, if you look at it Klinefelters, the excess dosage can keep on varying, and the increased number of X's does not alter the manifestation as much as one would expect. Okay, so the excess dosage is one theory that explains it, and probably it affects the regulation of the expression of certain proteins, which eventually will lead to the manifestation that happens. Like for example, in both in Edwards and Matau syndrome and in Down syndrome, you get a lot of mental retardation and slowing of mental development, but one of them is associated with a large amount of cardiovascular defects as well. Some of them are associated with a high risk of cancers. So it depends on which group of genes have been affected. Okay?
Thank you.
Right. It's all good. Can we end the session now? And you can continue discussing this on that WhatsApp group, and if you have any questions, you may ask me over there, and Saran as well. Okay, so I'm going to be posting this, and probably can start a discussion forum on that particular topic. All right. Have a nice weekend. Bye.